Okay, so as we were finishing up, and I was saying what we could do is if we reduced obesity among these individuals, we could likely change about 80% of diabetes cases that we see, because we do believe that this is such an important aspect to consider. Also, body fat distribution. Those with higher abdominal fat have an increased risk of diabetes. Advancing age, lack of physical activity. Poor diet has a question mark because we don't know that diet is related in and of itself. We think that it's related to the development of obesity, but more information needs to be done on that. History of gestational diabetes and presence of hypertension or dyslipidemia can also increase the risk of developing diabetes in the future. And one of the things that we know, so this was one of the hallmark studies, this was published back in 2006, that actually looked at trying to understand a little bit more of the nature versus nurture. And this is one of those examples of acculturation for immigrants as they come into the United States, in which they take a look at, is it the environment that they're now living in, or is it genetics? And so there's a couple things that I want you to be thinking about when we look at these migration studies, and that's what these are called in epidemiological studies, is we're looking to see if in individuals, when they migrate over, if it was totally genetic, we would expect that the individual's risk or development of disease would be similar to those that they see in their culture back home, and it would continue across all generations at the same degree. And so we would expect it to be just genetic, if it's just a genetic component. If it's an environmental component, then we would start to see rates increasing in the first generation when they move to the new culture, higher than what we would see in their native culture. And then with preceding generations, because the generations that are now born in the new culture tend to acculturate, which means they tend to become more like the new culture than their native culture, that we see even higher rates in those individuals. So what we've looked at here is we have non-Pima Mexicans rates, and then we have Mexican Pima rates. And so what we're looking at is those living in Mexico, according to this environment, what is the rate of type 2 diabetes or prevalence of type 2 diabetes among men and women in the Pima Indians. So this is looking at the culture, those living in Mexico that are Pima Indians living in Mexico, native to that culture. And we can see that they have a slightly higher rate than non-Pima Mexicans, which might show a little bit of a genetic component. But when you look at those that U.S. Pima Indians that have migrated to the U.S., you can see significantly higher rates in the U.S., which tells us that it largely has to do with environmental factors in terms of type 2 rather than type 1, or rather than a genetic component. So again, this further, when we think about the Western culture of low physical activity, poor diets, high levels of obesity, we can see those factors being significant factors in the development of obesity. So as we continue forward, there's some other specific types of diabetes. We see there's about a 1 to 2% of diabetics have this type, and this is usually caused because of some sort of injury, infection, medication, maybe another genetic syndrome, disease that affected the pancreas. So these are sort of what we would call sort of, because there are other types, because they're sort of anomalies to the development of it. It's maybe you got injured, or you had an infection, or there was a damage to the pancreas from some other disease that then resulted in it. And in these cases, it may or may not require insulin. It really just depends on the level of damage that has been caused to the pancreas in the utilization of insulin. Gestational diabetes represents about, it's a part of, we see this in pregnancy about 2 to 10% of the time. It's diagnosed typically during the second trimester through an oral glucose tolerance test. An individual will go in and has, so drink a certain amount of milligrams of this sugary drink. You test the blood before, you drink it. wait an hour, test the blood afterwards, and there's a certain criteria they have to wait into. If they fail that, they then go on and take a 3-hour glucose tolerance test. If they fail that, then they typically are needed to go on insulin throughout the rest of their pregnancy in order to help control gestational diabetes. It usually returns to normal after delivery. However, they should receive continued long-term follow-up and work to have similar interventions that we use for other prevention of type 2 diabetes. In other words, making sure they continue to be physically active and eat right and manage their weight. There's about 35 to 60% chance that they will develop type 2 diabetes within 10 to 20 years after having gestational diabetes. And of course, if they have it with multiple pregnancies, it further increases their risk. Some other things that cause their risk for development of gestation would be family history, a previous delivery of a large baby over 9 pounds, and of course, obesity can all put individuals at risk for gestational diabetes, the development of it. So this graph just kind of shows you a little bit of the disorders of glycemia and how it falls for individuals. And what you can see is type 1 is the only one that really needs insulin for survival. Many of these other ones need it for control and could potentially control it or reverse the disease by changing their risk factors for many of the factors that cause these types of programs, particularly type 2 diabetes and gestational diabetes. Other specific types, it's a little bit more hard to really control because those are usually done by some sort of injury or infection, like I said, sort of an anomaly in terms of that. So let's now shift gears and talk a little bit about what are the diabetic complications. There are acute complications such as hyperglycemia or hypo, and then there's more chronic conditions, which would include the macrovascular, microvascular diseases, and peripheral and autonomic neuropathy. For the acute complications, these need to be quickly identified to really have proper treatment and reduce the risk of seriousness that can occur with these particular complications. And so we're going to take a look at each of those symptoms and some of the sort of treatments to go forward with that. In particular, we talked about hypoglycemia and over time the damaging chronic effects that it can have and the need for insulin throughout. But what I want to focus on now is hypoglycemia, because this one typically causes sort of a response that is needing some really important, significant treatment right away. So there's two categories. There's autonomic and then there's neuroglycopenic. Autonomic is a reduction in blood glucose, and this is usually triggered through these various hormones. So glucagon, epinephrine, GH, and cortisol are released to help increase circulating blood glucose because of this. And so the epinephrine release actually causes a shakiness, weakness, sweating, nervousness, anxiety, tingling, hunger, kind of things that sort of results in like, hey, we have really low blood sugar and we need to eat something soon. And it's that's largely because of the epinephrine release. But these all these hormones are released to try and get more blood glucose in the cell whenever we see this. So this is an autonomic response. Neuroglycopenic is decreased blood sugar delivery to the brain, and this is where we have really significant drops or hypoglycemia at really low levels, and we start to have things like headache, visual distributions, mental dullness, confusion. It can even get to things like amnesia, seizures, or a coma may occur. So typically the treatment for blood glucose is if the individual is conscious. We really want them to consume about 15 grams of carbohydrates. Usually this can be like juice, popsicle, lifesavers, raisins, something with maybe sugar, honey in it. And remember, this is any individual that experienced hypoglycemia, we could use this, but particularly even with diabetics if they have a hypoglycemic episode. You want to wait about 15 to 20 minutes to allow symptoms to resolve. If necessary, consume another 15 grams. We don't want to throw a whole bunch at them at once because that can be also a little bit detrimental. If they're unconscious, then we inject glucagon. If that's not available, we call 911, obviously, as quick as possible. Exercise can lead to hypoglycemia, especially in diabetics, and we'll talk about that in a little bit. So it's really important that individuals will check their levels before and afterwards, especially if they're on insulin, and really have to consider when they're going to choose to take their insulin, because it can result in a hypoglycemic episode if they're exercising and if it just use their insulin. So we'll talk about that shortly here. So what are some of the chronic complications that we see from diabetes? And this is largely due to uncontrolled diabetes, or diabetes that continually progresses over time due to a lack of change in lifestyle or factors related to that nature. Leading causes of diabetic complications are adult onset blindness, lower limb amputation, and end-stage renal failure. There's also a 2 to 4 times higher risk of heart disease and stroke, and also intensive blood glucose control can reduce the risk of developing microvascular complications. So in order to really control these, we really have to control our blood glucose. Macrovascular diseases are typically include sort of larger vessel atherosclerotic kind of disease. So this would be your coronary artery disease, myocardial infarction, cerebral vascular accident or stroke, and peripheral artery disease as well. Microvascular would be in our smaller vessels. This would be diabetic retinopathy or diabetic nephropathy, so eye and kidney disease. And then, of course, we already talked about nerve damage in peripheral and autonomic neuropathy. Some of the primary risk factors for the complications related to macrovascular disease is genetics, abdominal obesity, and a sedentary lifestyle. So, we can control the abdominal obesity and the sedentary lifestyle. We have struggled with our control maybe of the genetics, but these would be the factors that we would need to really consider stronger control in diabetics to reduce the risk of macrovascular disease. And what this graph just kind of shows you is it really takes a look at, obesity, does a lot of things to increase the development of cardiovascular disease and diabetes and cancer just individually. But when you even think about it within diabetics, your adipocytes, again, are metabolically active. They're going to release TNF alpha, which can cause destruction to major vessels. It results in a cycle with the liver that increases triglycerides and free fatty acids that are flowing, which can continue to incur damage. These signals to the liver can result in thrombosis and development of atherosclerosis. We have glycinated proteins through hypoglycemia, hypertension, hyperinsulinemia, increased free fatty acids, and hypoglycemia because of insulin resistance at the muscle. And so all of this kind of leads to atherosclerotic lesions developing in these organs and tissues, because these things have to be stored and taken somewhere. This same level of atherosclerotic lesions occurring at large vessels can also occur at the smaller vessels, and it's this occurrence that leads to blindness and end-stage renal failure and microvascular diseases. So what this graph is really just showing you is the signaling pathways. Because of hypoglycemia resulting in insulin resistance, liver's not taking up glucose, skeletal muscle isn't, adipose tissue is already getting fuller. Those triglycerides, free fatty acids, cholesterol have to be put somewhere, so it ends up being stored in other organ tissues, and also increases in cholesterol results in atherosclerotic lesions, hypertension, and these other signals like the TNF alpha, which cause further damage to cells, results in an increase in atherosclerotic lesions, leading to macrovascular disease, microvascular disease in both of these areas. And so we have to consider this in our control of this disease.